Thank you all for joining me today. My name is Valerie Beeson. I'm the Clinical Programme Director for Lipotrim. As you can see with this first slide, the recent College of Physicians report, Action on Obesity, Comprehensive Care for All, called for GPs to direct obese patients to community services, including pharmacies. Well, today I'd like to report to you the excellent results already being achieved by pharmacies using the Lipotrim Weight Management Programme. We have a stand here today where we can discuss the programme in more detail. I'm not going to go through it with you today. I really want to show the results that we're getting in pharmacy and also about the patient tracker audit tool. And again, we have that on the stand so we can demonstrate how we collect the data. Lipotrim is a nutrient-complete, low-fat enteral feed. So the programme was designed for general practice over 25 years ago. It's not a new programme, and it's been available in pharmacy for the past 10 years. Women lose on average about 1 stone a month, and men lose 1.5 stone. Currently, 60% of the population are overweight, of which 30% are obese. If we assume a 60 million total for the population for the UK, this calculates to 36 million overweight patients and 18 million who are obese. It's unrealistic to assume there's only going to be one solution for this problem. Pharmacies run the weight management programme, they run Lipotrim, but it's also they offer other services at the same time. So healthy eating advice, we've got the government-backed Change for Life scheme, a healthy living pharmacy initiative. All of these things are working at the same time already in pharmacy. Short film here from Professor Haslam, just to discuss the evidence for VLCD.
I'm Professor David Haslam, I'm Chair of the National Obesity Forum, I'm a GP in rural Hertfordshire, and I'm a physician in obesity medicine at the Luton and Dunstable Hospital. When patients have become overweight or obese, then eating normal food has gone badly wrong. They've eaten too much of it maybe, they've done too little exercise maybe, there may be other factors such as genetic factors or environmental factors, but just eating normal food, something's gone wrong. And so by starting a diet such as a very low calorie diet, it's reversing the problems that eating too much normal food has done. And it's important to bear in mind that a modern very low calorie diet is nutritionally complete. It has got all the minerals, all the vitamins, everything that's necessary. So it's nutritionally complete. Nothing is being lacked by a very low calorie diet apart from the volume of food.
NICE requires that results be evidence-based, but given that Lipotrim can't be tested against a placebo, how can enough evidence be accumulated for the medical community to take such observations seriously?
VLCDs can't possibly be tested against placebo for obvious reasons, but there's plenty of evidence that tests VLCDs against standard care. So as a clinician, I'm interested in how well my patient does who goes off on a very low calorie diet compared to my other patients that are just under my standard care who don't go off on very low calorie diets. And there's plenty of evidence that suggests that VLCDs are successful not only in losing weight but in maintaining weight loss. Now, one thing that is important is that NICE back VLCDs. NICE deem them to be appropriate, but only in certain circumstances, which is that they have to be monitored by a healthcare clinician, which in the case of Lipotrim, for instance, can be a GP or it can be a pharmacist, and that's the monitoring there is very effective, and it's in many cases now that's done on computers as a monitoring of the week-by-week visits, which can be well audited. So there's plenty of evidence there, and the monitoring there is in place, and so I'm satisfied that this is an appropriate method for my patients.
Why is total food replacement necessary? We're talking about safe, rapid and significant amounts of weight can be achieved using a total food replacement programme. This is important for the control of type 2 diabetes. When we use a total food replacement formula, the patients have their medication stopped before they start the programme, as blood sugars fall to normal within the first week of the diet programme. Dietary carbohydrate is unavailable, so it forces the body to use the circulating excess dietary sugar and then onto the storage sugar. Rapid weight loss confers extra benefits again if we're losing for patients with high blood pressure. Very many obese patients have hypertension. Again, not all hypertension is weight related, but a high percent of those patients with overweight, high blood pressure is because of the weight problems. If we get significant weight off of the patients, we can see reduction in blood pressure and reduction in drug usage as well. We also see better long-term weight maintenance outcomes. People using total food replacement programs lose more weight in the first instance. Even if they regain some of their lost weight, they still have a long-term net benefit. They're keeping weight off. We also have an opportunity to encourage behaviour change. Not all people who have 1 or 2 extra drinks become an alcoholic. Equally, not all people who have overeats of extra food become addicted to food. But there are a lot of overweight, seriously overweight people out there who are addicted to food. And using a total food replacement program is the only way we can get them away from the substance of abuse, the food that they're eating. So it's not for everybody, but it is an option for people who really struggle with the addictive nature with food as well. Stopping the substance abuse. There's now a lot of evidence that excess food intake actually shares common brain pathways with what's seen in addiction with alcohol, tobacco and smoking. And of course part of the treatment for those other problems is to stop the substance of abuse. We can't do that with normal food. We need the nutrients. So using a formula allows the substance of abuse to be stopped for these people who've got significant weight problems. Moving on to the data collection and evaluation, we have the Lipotrim Patient Tracker Programme. This is a really powerful tool. It's a web-based secure data collection programme, and we can manipulate the data for audit. The pharmacist will be seeing patients on a weekly basis and entering the information onto the computer. We can look at males versus females. We can go for age range, BMI ranges, medication usage, and we can even track the patients from a particular GP practice. This is valuable in providing evidence. Pharmacies are out there collecting data now. There is a massive amount of data already in the system, and I'll be giving you some of the results today. This is going to be important for the Healthy Living Pharmacy Initiative, where those pharmacies have been trained to give extra service in their different services they're providing, and they need to show that they're getting better results and evidence as opposed to standard treatment practice. Next short film discusses the audit function, so it's actually showing you part of our tracker programme and how you can look at the data and do the audit. We have the tracker programme here on the stand, so if anybody would like to actually look at it and look at some data on there, we'll be able to demonstrate that today.
The Lipotrim Patient Tracker Audit Function. Auditing your data powerfully demonstrates to you, your patients, doctors and commissioning groups the excellent work you are doing to tackle obesity. You access the audit function via the Reports tab. The first thing to do is click on Set Filters here to bring up a box where you can pick certain aspects of your database to display the corresponding statistics. We will firstly look at a simple audit. By leaving this box with its default values, we'll be looking at an audit of both males and females, those presenting with an age range between 18 and 76, those with any starting weight, with a starting BMI above 20 and a finishing BMI above 20, and those who have completed 3 weeks or more on the total food replacement programme. Basically, we want to see how everyone who took the diet seriously did. We are, however, going to look at their first attempt in isolation. This means if they have successfully completed more than one weight loss cycle, only their first cycle is included in this audit. We're going to also view all patients by leaving this box unchecked. Set filters. This takes us to our data report. Before we audit this data report, it's important to now show you where to find records that haven't been included. The Records Not Included link shows you the list of patients excluded from your filtering of data earlier. The next link is of great importance because it's here in the Problems Record link that you can find data input errors not automatically obvious. For example, by checking this list for extremes of BMI, you can find original height and weight input errors, potentially excluding excellent data from your audit. Once we're happy to proceed, we can then click here to audit the data set. The audit displays the total number of patients and the total of weight lost, and also a wealth of averages in terms of BMI, weight and age. One very important piece of information is the weight loss percent of initial. If this value shows anything much less than 10%, if auditing the total food replacement programme, you need to reassess how you deliver your service because your patients are underachieving. Please note you are given the most commonly used method of averaging results, the mean range, but you're also given the median range. The median range is the halfway point of your data. For example, if looking at the age range of 100 patients, the median value would be the age of a patient number 50.
Now, as you can see, that's a typical set of audit results from a pharmacy. We're going to look at some individual pharmacies and their results, and I'll talk you through those. This is audit results of the Lipotrim service at Prestwich Pharmacy in Manchester. The total number of patients requesting the diets, over 1,700, a significant number of patients in one pharmacy. The number of patients completing at least 2 weeks on the diet programme, 1,148. And what we do see across the board in the pharmacies is around 80% of the patients attending are female and 20% are male. And this is borne out in this particular audit, 948 females and 200 males. The average BMI at the start of the programme was 34.82. And the median, half the patients were at BMI 33.6. And note the highest BMI in this audit was a patient of 66.4. The total loss to date for these patients is over 12,000 kilos, with an average weight loss of 10.71 kilos. 96 patients lost more than 3 stone, 20 kilos, significant weight loss in community pharmacy. 52 lost more than 30 kilos, which is 5 stone. The average percent of the initial weight loss was 11.3%. But look at the median here. Half the patients lost more than 9.7% of their weight. And in this audit, this is over 500 patients in this particular pharmacy. Significant results out there in the community in the pharmacy. 103 patients lost more than 20% of their pre-diet weight, and 14 patients lost more than 30% of their pre-diet weight. This is in just one single pharmacy. We have over 2,000 pharmacies offering a weight management service, of which Lipotrim is part of their offering. These two graphs, I'm not sure if people can read all the figures from the back. The typical graphs, the top one is the weight loss graph for a particular patient, starting at 140 kilos, and over the course of the diet period, which is around 6 months, dieted down to, I think that's 80 kilos. So 60 kilo weight loss, very obese patient, seen weekly in a community pharmacy, doing well, losing weight. Percent weight loss of initial, 60%. Of initial weight loss for this particular patient. These graphs are typical in most pharmacies. They show the weight loss progress of a compliant patient. The patient tracker allows that the pharmacist can show the patients their weight loss graph on a weekly basis and they can see their progress. Looking at another audit from a different pharmacy, 382 patients here, a slightly different split, 330 females, 52 males. The starting BMI, the average was 32.7, down to BMI 29 at time of audit. Remember, a lot of these patients are still dieting. This is just a snapshot time of when the audit was taken. Now, the patient tracker programme allows for different subsets of patients to be put into different groups. We can look at BMI groups, we can look at age groups, we can look at gender groups, and these next set of slides are showing this audit broken down into different BMI groups. On the top table, BMI 25 to 30 overweight patients, 121 out of 382 in the audit were in this category. The The average BMI changed down to 25.4 from 28.1. And again, the median is important here because half the patients, 60 in total, are no longer overweight. This is significant for disease prevention. We want patients to come into pharmacy at an early stage to lose their weight before they become obese, before they're diabetic, before they're hypertensive. There's local pharmacies all across the country offering weight management services that are easily accessible for the patients to attend. And if we can get people in early, the overweight categories, before we have the medical problems, this is going to have a major benefit on cost savings in the future for the health service. The next category, the obese patients, BMI 30 to 35, again, there are 141 patients in the audit in this category, and their average BMI changed down to 28.9 from 32.4 at the time of the audit. And again, their percent weight loss from initial was 10.9%. Again, the median is important here. Half the patients, so that's 70 patients in this case, lost more than 12% of their initial weight. So significant results in community pharmacy. The next set of patients, super obese patients, BMI 35 to 40, in this one pharmacy, 73 patients in that BMI bracket, demonstrating that large BMI patients have no problem attending community pharmacies to access a weight management service. Again, similar results, big amount of weight to lose, a higher percent initial weight loss, 12.9% on average, and the median, half the patients losing more than 11% of their initial weight. These next two tables from the same audit represent 34 patients who would have been eligible for bariatric surgery. So if we assume £10,000 for a basic surgical procedure and some follow-up, in this just one pharmacy, if those 34 patients had chosen that route, it would have cost the health service £340,000. Remember, we have 2,000 pharmacies in the system, and this is just data from one. The first group, there's 29 patients, BMI 40 to 45, significant end BMI at time of audit down to 36.1 from 42.2, with a 14.4% weight loss from initial. The other 5 patients in the super morbid obese category, BMI 45 to 50, the mean range have lost more than 10 BMI units with a 21.2% weight loss over initial. Very, very significant change in these patients. Talking about the audit, the NHS statistics for 2011 showed that 53% of obese men and 44% of obese women suffer hypertension. We now have a new function on the patient tracker programme which allows pharmacy to record the changes in blood pressure medication so evidence can be accumulated for future audit. Obviously there'll be an issue here for prescribing cost reduction if we can monitor this data. When the patients attend a pharmacy-based programme and they are hypertensive, the pharmacist can obviously monitor the blood pressure while they're losing weight, or there may be a medicines use review in place with the local GPs. 22 patients in this one pharmacy audit, the average start BMI was 36.2 with an end BMI of 32 and 11.6% weight loss. They may or may not have had some changes in blood pressure which would have been measured, and if the blood pressure had come down significantly with the weight loss, then medications would have been stopped or reduced. This is an interesting slide. We're talking about patients that we call it the maintenance phase. So when they've stopped the dieting part of the programme, the weight management programme's 3 phases. The first phase is total food replacement, where they're not eating any normal foods. Then they go on to a transition period where they refeed back to normal food. And then they're what we classed as maintenance patients. And they are able to attend long-term in community pharmacy to be weighed for follow-up and just keep in touch and keep an idea of what's happening to their weight. So in this particular audit, there's 119 patients who have been through the diet part of the programme and have been maintaining for at least 1 month. The average time on maintenance has been around 7 months, with half the patients, the median, half the patients having been stable at 5 months after the diet, and a maximum recorded time of 2.5 years stability. And again, as you can see from the start BMI, the average BMIs at start and end, basically their BMI, their weight stable in the maintenance phase. This slide is the first BMI, meaning the BMI at the end of the diet period, and just the blue line overline oscillating changes in BMI, roughly 1 or 2 BMI units change in the maintenance phase, 1 or 2 spikes where patients have gained weight. If we look at this on this slide a little bit more clearly, if you see half the patients have gained 1 or 2 BMI units after the weight loss phase, and half the patients have actually lost 1 or 2 BMI units. So considerable maintenance stability, and just a few patients having regained some of the lost weight. Pharmacies do offer a maintenance programme, so it's not just about a diet. When they come in, it's weight management. So pharmacies will screen the patients. They can choose to do the strict total food replacement programme, or they may be offered another option in the pharmacy. All this information can be collected and stored on the patient data records. We have a unique maintenance programme. We use some formula foods in conjunction with normal food to help patients who have problems with insulin-resistant changes after they've lost weight. And again, patients are able to come to pharmacy long term to help with lifestyle change and healthy eating advice. This is a very important slide. This is over 10 years old. It's the Anderson slide published in the American Journal of Clinical Nutrition. And it's an audit, a meta-audit of 29 published maintenance studies. The top line, I'm not sure if people can see at the back, are different VLCD programs, the results, the weight loss results over the period of time, and how much weight has been kept off at a 5-year period. The average, the line through the middle is the averages, and the baseline is the amount of weight kept off with different programs of hypercaloric balanced diets. And you see from here, it's clear that VLCD diet has lost considerably more weight than the hypercaloric balanced diet is in the first place, and at 5 years, the VLCD dieters have sustained a weight loss actually greater than the total loss in the hypercaloric group. So this is why it's important when people have a lot of weight to lose, they have an option to use a total food replacement programme, a VLCD, to get as much weight off as they can, because even with some weight regain, the long-term data reflects that they are keeping weight off. This is a further audit of Irish pharmacies, a very large number of patients here. So patients having lost 5% of pre-diet weight or more, over 10,000 patients in this audit out there in community pharmacies losing weight. The total weight loss by those patients is nearly 118,000 kilos. The average weight loss of initial 11.5%, but importantly again the median, half the patients lost more than 10% of their pre-diet weight. In this audit we're talking 5,000 patients having achieved this, attending in pharmacy. Very, very important that consistent results are being achieved by all the pharmacies, and we can collect this data on the patient tracker programme. Again, the same audit from Ireland. These patients, almost a quarter of the patients are in the maintenance phase. So they're attending pharmacy long term, monitoring their weight loss progress. If they regain weight, they can join in. They can get advice about healthy eating. It's free. The pharmacists are available to help them. And the maintenance range, the average time for maintenance is 6 months here to up to 4 years. And as you can see from the average start BMI and at last visit BMI, which can be as much as 4 years, their weight's stable and the BMIs are stable. So these are consistent results from pharmacies. There's now a short film clip for Professor Haslam, who's been just discussing diabetes.
With significant weight loss, many medications can be reduced, and this has been shown in a lot of studies that the prescribing costs after weight loss do reduce dramatically. But it varies with different conditions. For instance, in patients with type 2 diabetes, there needs to be an immediate reduction, if not a cessation, of anti-diabetes medication. With high blood pressure, it tends to be a more slow reduction in blood pressure, and so blood pressure medications can be knocked off at different periods of time after weight loss. Weight management can be carried out in many different arenas. It can be in my surgery as a GP, it can be in my nurse's clinic, or it can be in a pharmacy. Pharmacy are doing more and more with weight management as part of their public health campaigns and their new contracts. Now, I think they're ideally placed to manage weight because they access a lot of our patients who get their repeat prescriptions, so those with chronic diseases who need to be seen regularly. Also, they see people who would never come and see me, they would never set foot inside my surgery. So pharmacists in many ways are ideal healthcare clinicians who can be involved in weight management.
Currently, there are about 3.7 million people in the UK who suffer with type 2 diabetes, and of those, 850,000 are type 2 diabetics and they don't know it. The majority of these people will be overweight. So if there's easy access to weight management in community pharmacy, this is an important goal to strive, that we can get those patients in early, detect the diabetes, get the weight off them before it progresses to medication and further ill health. And obviously pharmacies are already offering lifestyle assessment and diabetes risk assessment. We need to make this paramount, that pharmacies are there helping with the weight management to stop the increase in diabetes. Next week, there's actually a joint meeting with the Royal Pharmaceutical Society and the Royal College of General Practitioners. And the doctors are asking for a more collaboration and integration with pharmacy services. They want patients to be seen through pharmacy, diabetics, and shift the emphasis to prevention and early detection through pharmacy. So the GP's role is looking after compromised patients, the ill patients, not the ones that can be seen through pharmacy with other healthcare professionals. So it'd be important that this initiative will get off the ground and GPs are recognising the role that pharmacy can play. This next short film clip is Dr. Haslam again, Professor Haslam again, discussing VLCD with diabetes.
It's been said by surgeons that other than bariatric surgery, there are no other treatments that put diabetes in remission. But Lipotrim claims to produce results that are comparable. What would you say is its impact on type 2 diabetes?
There are various methods of weight loss that an individual can use, ranging from walking the dog to going to the gym to calorie counting, and each one, there's a whole spectrum of the amount of weight that a person can lose. Each one induces a different degree of weight loss. So if someone has just been diagnosed as having type 2 diabetes and has just crossed that threshold of sugar levels, of glucose levels, then actually any weight loss regime can put diabetes into remission. But there are areas such as the very low calorie diets and bariatric surgery in which a person loses significantly more weight. It's a much more emphatic degree of weight loss. And so these methods can put someone with type 2 diabetes in remission, even if they've had diabetes for quite a long time, even if they're on insulin and multiple different oral medications. These are the two methods, it's quite right, they can put type 2 diabetes into remission. It's important to remember that 90% of patients with type 2 diabetes have their diabetes because of the excess weight that they carry. And so it's perfectly logical to use regimes such as Lipotrim in order to reduce the weight, and we know from the evidence that with that weight reduction that blood sugars can be normalised, so patients can go into remission of diabetes, which means their sugars are normal without any anti-diabetes medication. So certainly Lipotrim and other very low calorie diets are ideal for the type 2 diabetic patient.
Moving back to the Irish audit, the 10,000 patients, we're looking at, within the period audit, 65 patients were identified who had both completed at least 2 weeks on the Lipotrim programme had also reported type 2 diabetes. Now, unfortunately, this number's quite low in that number of patients, and the reason for this is pharmacists need cooperation from the patient's GP in managing their medication when they're diabetic, because when they start the total food replacement programme, medications need to be stopped or reduced at the outset. So we need to have a bigger awareness campaign with the GPs that pharmacists are able to offer this service and help with the diabetic patients. Now, of these patients attending, 5 were gestational diabetes, 14 were already diet controlled, 1 was found not really to be diabetic at all, and 22 of the patients failed to successfully diet beyond the 2 weeks, which left 23 successful dieters with type 2 diabetes in the pharmacy audit. 10 were female and 13 males. Now look at this list of drugs. These represent the drugs that these patients were on. These medications would have been stopped at the outset of the diet programme in conjunction with the patient's GPs. Again, long term, we're looking at massive cost savings if we can get people off the medication. And what we find is when people lose weight rapidly with a total food replacement programme, we get better long-term maintenance results, there's less weight regain, and there's also better long-term glycemic control when people can lose weight more quickly, which is significant for the diabetic patients. So very few actually have to go back on the medication because they're attending pharmacy long-term. They can get maintenance help in community pharmacies and manage the diabetes. So if we can stop these medications, it's a big difference. And again, it has to be done in conjunction with the GPs. If people are carrying on with some of these drugs with a total food replacement programme, we could cause a hypoglycemic attack. So we have to have the GPs in the loop to help the pharmacists to do this. Looking at these particular diabetic patients, the average age was 53.7 with a start weight of 120.2 kilos. They all lost, on average, 3 stone during the course of the weight management programme. They all would have been off their medications and none of them are back on them. The start BMI was 41.2 and the last recorded BMI was 34.1. The duration of diabetes remission, 10 months. Again, the range significant from 1 month to over 4 years. This is typical type of results we see for the diabetics in pharmacy. Moving on to comparison with bariatric surgery. There are large numbers of publications in which it's claimed bariatric surgery results in complete remission of type 2 diabetes, and that surgery is the only weight loss method that achieves remission. We know this not to be true. The pharmacy programme has been out there for more than 10 years and we have significant results to show there's significant weight loss and remission of diabetes with total food replacement programmes. And often, with the diabetic patients, this claim about the remission is justification to spend that money because they want the remission of diabetes for the patients. But, however, they've been looking at new studies and it's been found that there's not so much remission of diabetes after surgery as was thought before. This is a very recent publication, January 2012, in the British Journal of Surgery, and they're discussing different bariatric procedures and the rates of remission for diabetes. There were over 1,000 patients underwent bariatric surgery. 209 of them were suffering type 2 diabetes. 72 of these, only a third of the patients, had complete remission of diabetes after the surgery. The remaining 137 diabetics patients still required some diabetic medication following the surgery. Now, it's important if we break these number of patients down into the different bariatric procedures performed, and really it's only the most serious operation for the patient, the gastric bypass, that's giving the highest level of results of remission for diabetes, and then it's only 40% of the patients will have remission. A sleeve gastrectomy, again, only part, but they may go on to a further set of surgery after sleeve gastrectomy. 5 out of 19 patients had complete remission of diabetes, and only 2 patients after gastric banding. So for a diabetic patient, the gastric banding may not be a reason to have that operation, thinking they're going to get remission in diabetes, because clearly it's not giving the results that they once thought it was going to. Sustained remission requires both rapid weight loss, as seen with total food replacement, which is present in surgery, but we also need prolonged carbohydrate restriction, which is not present in surgery. Patients very soon after bariatric surgery are eating normal foods again, normal amounts of carbohydrate, and they are not carbohydrate restricted long enough while losing weight to sustain diabetes remission. We need to have a greater understanding of what's needed to have the effect on the diabetes. So it's not just the surgical procedure, there needs to be more follow-up, and a lot of the data coming through now is showing that we don't actually get the remission after the surgery. Ketogenic VLCDs, which by definition are low in carbohydrates, keep blood sugars normal throughout the weight loss period. So patients are carbohydrate restricted, so we do get the remission in diabetes. We do get much better long-term glycemic control. And this is borne out in lots of published data. Rena Wing has done a lot of work in this field, and there's a lot of published data about glycemic control after rapid weight loss. We also see the amounts of weight lost, and even if there's weight regained, people still have significant maintenance data and weight kept off. And with reasonable weight stability, the remission is sustained. And we have the data in the pharmacies to support this. And we can monitor this data long term on the tracker programme, because patients will be coming to pharmacy over a long period of time, and we can collect more data from them.
It's described by those who run its program as a low-calorie, nutrient-complete enteral feed. Lipotrim offers, they say, significant weight loss for patients, among them diabetes sufferers at risk of early death from cardiovascular disease. 1,200 people have undergone the program at this pharmacy, one of a large network of pharmacies and GPs offering the service.
How useful do you think Lipotrim is in terms of easing the symptoms of type 2 diabetes?
It's not so much that it eases the symptoms, it actually removes the need for their medication. Those people who come in and stick to the program and lose the weight, they're off the medication for life, providing they maintain the weight loss. And we've had a significant number of people who've been able to do that. The benefits to the patients are fantastic results. Within a week, they're seeing results immediately, and within a month, they've lost a stone to a stone and a half, depending on the patients.
With diabetes estimated by experts to cost the NHS £1 million an hour, and with Lipotrim privately funded, it's argued that making it available through pharmacists eases the burden on the health service.
There are currently 800,000 people who meet the NICE guidelines for bariatric surgery. Only a small percent of these people will choose to have bariatric surgery. Even so, 8,000 procedures were carried out last year, and over half of these were privately funded. Patients paid, went abroad, went elsewhere, so the NHS were funding only about 4,000 procedures. If we doubled that number this year, it's a drop in the ocean. Remember, 36 million people are overweight and 18 million are obese. So surgery is not the way forward, and should be reserved for the patients who most at risk of dying from their obesity. There are so many options for patients to go to other services to lose their weight rather than go for the surgery. So it should be really kept for the most obese patients with the most complications and other serious risks. The NHS is set to spend over £300 million over the next 3 years to tackle the shortage of weight management programmes. It is imperative that pharmacy play a lead role in providing weight management services to benefit both the patient's health and the NHS in cost saving. We can reduce the drug bill, we can reduce the surgical burden, and that's all surgery, not just bariatric surgery. Overweight, obese people suffer problems with hips, knees, joint, all the other surgical problems that arise and health problems arising from the obesity. If we can see patients early enough and prevent the problems in pharmacy, we can save a lot of money long term for the NHS, and especially for diabetes and future ill health. But one of the important things that we need to do is make GPs more aware that we can gather the evidence in pharmacy. We can support the role of pharmacy in weight management and diabetes prevention and remission. There will be massive cost savings to the NHS and patient health benefits. We do have a stand here today in the main exhibition hall. We have got the patient tracker there, so those audit results you see, it's literally a click of a button. Once the patient data's in there, had a look at what the pharmacies have produced, we can produce an audit. The pharmacists can see how many patients they've got on board, how much weight they've lost. The patients can be shown a weight loss graph. All of this information is readily available instantly to any pharmacy offering the service. We've got some published documents there, a little bit more background on some of the topics I've touched on today, so there's some published articles there if you'd like to pick those up. And also, I haven't really told you much about what the programme entails and all of the intricacies of it, but we can discuss that if you'd like to, the GP programme and the pharmacy-based weight management programmes. And thank you very much for your time today.